Happy Sunday. This is Sunday Conversations with Wendy on the TFCC. Today I wanted to go over the ECU. Of all the things that I see over the course of time, it's how many questions that we have about the Extensor Carpi Ulnaris. So the Extensor Carpi Ulnaris, I just want to go over the anatomy first. The Extensor Carpi Ulnaris starts at the lateral epicondyle. So there's these two bones that go on the outside and the inside of the elbow. And the Extensor Carpi Ulnaris goes to here, starts here, turns into a muscle relatively quickly. It's a very small muscle that goes and attaches at the base of the fifth metacarpal. And the muscle itself is not a very strong muscle. It's long and thin, and it has an important role in just ulnar deviating and extending the wrist. The insertion, when it comes over here, it goes through its own little tunnel, the sixth dorsal compartment. And that tunnel, there can be a lot of things that go wrong with the Extensor Carpi Ulnaris. And what we see typically is people with a TFCC tear develop Extensor Carpi Ulnaris subluxation. There are people that develop Extensor Carpi Ulnaris subluxation because of an injury to that sixth dorsal compartment, and it's really important to distinguish the two. And the best way to distinguish the two is the Weightbearing Test. So if you put your wrist on in extension, that Extensor Carpi Ulnaris is placed on slack. And so when you do the Weightbearing Test, people that have an injury to that sixth dorsal compartment, or the little tube that the ECU goes through, they have normal and pain-free weight-bearing tolerance. And that is an important distinguishing factor. And they can sublux as you go into supination. So I just wanted to go over what the dynamics are as the wrist goes into pronation and supination. So this is supination, and it takes a turn, and then pronation, and as you go into pronation, it's straight, and the sixth dorsal compartment is about here. So you can see in a normal wrist what happens is as you turn into supination, this gets tensioned. People that have Extensor Carpi Ulnaris injuries here, you put them in a wrist extension splint and hope that heals. It's a very simple surgical procedure. After the surgery, to repair the tunnel that it goes through, there's a protocol that you follow, and it's a really quick recovery and a pretty straightforward surgery. But most commonly, we see Extensor Carpi Ulnaris as a consequence to a TFCC tear. This band that goes around, there's two bands. There's the sixth compartment, and then there's one fascia band here, and I've taped it here to demonstrate it. It serves to hold that ECU in place. And what happens is when the distal radius and ulna, you get a TFCC tear, the distal radius and ulna spread, and that spreading puts tension on that spot and will stretch that dorsal compartment and contribute to that subluxation. And so what we see usually is the patient will develop a TFCC tear. That TFCC tear is that fascia goes kind of onto that TFCC and is now stretched. And now you get the subluxation of the ECU. And once you treat that TFCC tear, the ECU kind of resolves over the course of time, and it's predictable. Now, the longer you have a TFCC injury, the higher incidence you have of ECU tendonitis, because that tendon moving through this rubbing, not going through that tunnel very easy, kind of hitting the walls, will develop into a tendonitis. And so as your weight bearing improves and you get to the point of stability, which is at 60-65 pounds, then you'll see that ECU calms. The other thing that's always fascinating me is I wonder if there is a correlation between the function of the ECU and the development of a TFCC tear, and this is important. So the Extensor Carpi Ulnaris is innervated by the posterior interossei nerve, or PIN, and it's a division off of the radial nerve, and the radial nerve starts at the neck, and it moves through the arm, and it goes down, and it wraps around the humerus, and then it supplies the supraspinatus, the teres minor, the triceps, the anconeus, the brachioradialis, and all of the extensors of the wrist and the extensors of the thumb and the abductor of the thumb. And when that nerve is pinched, it's not conducting electricity through that radial nerve. And there's a lot of points along that nerve that can get pinched. It can get pinched at the neck, it can get pinched in the shoulder blade, it can get pinched on the tricep. And when that happens, you don't get firing of that tricep, the extensors of the wrist. And so you see a generalized weakness of the extensors. You see weakness of the lats, the subscapularis, the tricep, the anconeus, and the extensors of the wrist and the fingers and the thumb. And I wonder if that is first and then lends to a TFCC injury. So it's really important that you understand the mechanics of the ECU, and you also understand the importance of the nerve. And so what the mechanics of it and the position of stretch is with your elbow bent, your wrist bent, and your shoulder back. So you may get, what I recommend is that if you have ulnar-sided wrist pain, is that you start in a anatomical position, usually on the ground. So you start with the palm out. This is the starting point for all anatomy. And you start by bringing your shoulders back, straightening the spine, putting your hands first in supination, because that's the start, and then go into pronation. And as you squeeze and extend your neck, you want to see if you get an increase or a decrease in subluxation of that ulnar nerve, of the radial nerve and the ECU. So it's important to start at the neck and move out to the shoulder blade, and then to the elbow, and then to the forearm, and see if you can identify any spots that when you stretch, they cause an increase in subluxation of the ECU. The other thing is that you can predict that there is a tightness in the Extensor Carpi Ulnaris muscle itself, and that's where the deep tissue massage and the stretching comes in. You don't want to be doing the stretch with it completely rotated like this. So you don't want to be doing this sort of stretching. You want to do this sort of stretching to get the ECU, specifically the muscle. If there's any injury along the tendon-muscle system in any part of the body, what will happen is the muscle will pull, it'll contract, the nerve will pull that in, so you get this tightness. So it's a management program to massage and heat and stretch the ECU, but it's more important to kind of look at the whole system, the shoulder blade, the spine, and then the wrist. Okay, acupuncture helps. There is a correlation between the extensor here, Extensor Carpi Ulnaris, and the gallbladder. So I recommend people that have ECU issues that kind of just appear out of nowhere, that they look at digestive enzymes or some coating of the stomach to see if that helps any heat in the ECU. Acupuncturists will help you with that. E-stim is also helpful. If you put electrical stim on the nerve and the muscle, it will stimulate it and help blood flow and the connection between the mind and the arm. Splinting is detrimental to the ECU. If you put the wrist in extension to rest the ECU, that's a good plan if you've got an injury here. But if you put a splint on the wrist and you leave it there for a long time, what we find is that actually you fight against the wrist splint to use so that you can function with your hand. You need 45 degrees of wrist extension to function. And so if you've got a splint like this and you're trying to go function, you'll actually aggravate the ECU muscle. You don't want to be doing any supination with an ECU injury, which is painful with a TFCC tear anyways, but any sort of supination with wrist curled and elbow bent is going to put that on stretch. Okay, I'm hoping that we get Alison here. Alison I contacted. She's a CHT hand therapist in Texas, who is quite skilled at addressing nerve pinching issues, particularly at the PIN, the posterior interossei nerve. She's going to log in here pretty quickly, but what we do is taping. I like kinesio taping because it doesn't interfere with function, doesn't interfere with motion. It gives you a mental reminder when you're putting the ECU on stretch. And so how you do that is you get some of this KT tape, and there's a large variety of colors and better qualities than others, and a lot of dynamics of this tape that are important. You want to spend time on getting the product that works for you. But what you do is the objective is to place that ECU on a little bit of slack, place the tape here, pull it along and go to the origin of the muscle, and put your wrist into elbow extension, place it here and put some tension on it, and then adhere it down. And what will happen when you do that is when you go into flexion here, you'll get feedback that is a stretch. There's also taping techniques to address a pinched nerve, and those get a little bit trickier. You can tape it in such a way that irritates the nerve, and you can also tape it in a way that alleviates the pain. And so what you want to do is be patient and try a bunch of different things. Before I forget, I do think that doing a taping across here and here is helpful to keep that ECU along its path. So I taped it here with a pull medially, so that you can support that ECU from subluxing over that on the head. There are some taping techniques where you curl it around the elbow, and that gives a little support to that posterior interossei nerve that often gets pinched at the elbow. And then there's some taping techniques where you pull your wrist here, your forearm here, so that also gives a little bit of takes off the tension on the pinch location of that posterior interossei nerve. You can do some proximal taping and you can do some distal taping, and see if as you start in anatomical position, as you go into pronation, your pain goes away, and that's a good indicator that you're on the right road. The strengthening program that we have is important too, and it addresses the extensors of the upper body. And so we do lat lifts, tricep work, brachioradialis work, and then extensor. We don't do any strengthening of the extensor carpi ulnaris because of the risk of tendonitis. All right, I think that's a good basic summary. I wanted to answer any questions that you guys might have. Let's see. Hi, Island Daisy. Okay. So one of the things you can use to figure out what to do when is, do you have pain at rest? Do you have pain to touch? Do you have pain with stretch? And do you have pain with function? And that determines kind of what you do. If you have pain at rest, you want to avoid any stretching. You can move to ice and consider more resting taping. So you pull the extensor carpi ulnaris into a position of slack, and you nighttime splint. So nighttime is important. We do this a lot at night. All of us. What we do is we put our flexors on slack when we sleep at night, and this will irritate the ECU. So you can do a nighttime splint that puts the wrist in extension. You're not using the wrist at night, so you don't have risk of fighting against the splint. So if you have pain at rest and pain to touch, you want to protect it, kind of guard it, let that calm. You can check on the nerve. You can do nerve gliding exercises. You can strengthen the back, the neck, and the shoulder without any risk to the ECU. You can do the weight-bearing test to see how your TFCC is doing, and get a good grasp of where you're at. If you're inflamed and irritated and you have pain at rest and pain to touch, then you treat it with ice and rest. If you're pain-free at rest pain-free to touch, but you have pain with rotation, then you have to look more at mechanical and see if there's some taping techniques you can do to move that allow that ECU to move smoothly. Then you do a gentle stretching, gentle nerve gliding, gentle range of motion exercises. Continue not to use your arm too much. And then after pain-free with range of motion, so you're pain-free at rest, pain-free to touch, pain-free with normal range of motion, then you go to a little bit of function. You can start functioning with your hand normally. So you can start doing general functional tasks, assuming that your weight bearing is above that 45-pound mark. And then you can start using your hand, taking special attention to your mechanics, and taking time out of your day to do some stretching and deep tissue massage and heat. And it takes about 30 minutes in the morning, 30 minutes in the afternoon. You go to bed, you wake up, you're pain-free at rest, pain-free to touch, pain-free to the active range of motion. And then you can start some resistance exercises to your triceps. You can do some brachioradialis strengthening. You can do some lat lifts. You can do more dynamic load. And then start doing some gripping exercises. So you're taking that Extensor Carpi Ulnaris, you're squeezing that muscle, and you're seeing how it tolerates that new load. And you should progress nicely. Now, if your TFCC is injured and you're below 45 pounds of weight-bearing tolerance, your ECU is going to bark, and it's going to bark for a while. So it's important that you don't push it too hard when you're in that below 45-pound weight-bearing tolerance. All right, Alison. Hi, Alison. Yay. You want to call in, Alison, and give us your perspective on ECU taping. Hi, Lulu's. Hi, Phoebe. Hi, Carolyn. Let's see if I can get Alison Taylor on. Send me your questions. And let's see. All right, Alison. I would recommend that any of you that have your suspect of having a
Hey, sorry. Oh, God. I'm just technologically challenged is what I discovered. I've been recording all this stuff all morning, and I was like, oh my God, I just missed it. So, and then I realized I didn't know how to get on. So, I'm sorry I missed some of what you said, Wendy. But anyway, ECU taping. It's a little tricky. Somebody just wrote to me today about how would you stabilize like an ECU subluxation. So I'm going to see if I can show you that, first of all. It's one that we usually do in kinesio. You need a piece that's probably about this long. You do little triangles. So the moon, if you do a moon, they go too big. So little triangles like this. Rounded up some teeny scissors. I've realized my kids have stolen all my scissors. Around the edges. And this is a really good one for TFCC as well. So you take it, it could actually be a little bit longer, but it looks like this. So you actually tear this in the middle. You fold back your tabs like so, okay, like this. And you actually are going to put it over middle and index when you do this. And then you pull this down all the way, like so. And if you really want to keep this area nice and still, what you do is you put your wrist into extension, and you take your tape and you pull it to about 50% tension, so where you can kind of see the light through it. And you take it and anchor it there. And then you have no tension, which is super important. And then you go the other way into flexion, and you can do it the same way, about 50% tension. Anchor it right there. Oh, I can get it to stay. Sorry. Like so. And then have no tension. And then what you do is you want to pull it up and you want to pull it down. And so what it'll do, if you make it nice and snug, it'll keep you kind of still right on that corner, which is really cool. And then you can take another piece. There's multiple ways to skin a cat, but then you can take another piece that can be a little bit wider, or you can make a whole 2 inch if you wanted to, and then take it and anchor it right here. And you can get that pisiform to come up and really kind of, I would put it in that shortened position again, high tension right to the middle of the wrist, and then no tension. So you got to make sure you have, if you're going to have high tension taping, you don't want to have high tension all the way to the anchors and ends. So start with no tension, high tension, no tension. And what's interesting is a lot of times, I'm not sure if I have a big enough piece here, but a lot of times if you're talking about that imbalance, the FCU and the ECU, if the pisiform pulls down, FCU is over dominant, ECU is now weak, and it's kind of dropping down. So it's not unusual to take another piece of tape, and I actually, let me see if I've got a wider piece. I gotta look and see if I have it in here. Oh, yep, boring beige. So anyway, so we can take boring beige. Actually, it was the original color. It has no dye in it, so it's good if people have sensitive skin. You can take a wider piece and you can actually come up a little bit higher on that fifth metacarpal, like here, anchor it, and kind of do it at an angle too. And you can bring this back nice and snug right here. Again, there's multiple ways to tape. A lot of times I'll do pisiform. But this kind of stuff, when you have an ECU, you got to kind of bring out the big guns and be a little bit more deliberate about what you're doing. So it wouldn't be weird to add another pisiform tape to it. But I'll make this little, this guy's little. So one more if you wanted to. So this kind of a combination. It works great for TFCCs. There we go. We're on pisiform again right there. Sorry, it's pink. And we're going to pull that up. A little hard to do on yourself. Sometimes you need to get somebody to help approximate that joint up, kind of push that pisiform back in line with the ulnar styloid. That helps restore some balance between the FCU and the ECU. But that feels pretty comfortable. And so if you guys want to play on that on yourself, that's kind of a good way to do it. I would say that's the most stabilizing way right now that we have with the tape. So
can you talk about the posterior interossei nerve taping over at the elbow?
Yeah. So we have, let me see, I've got a little bit more tape left. So Wendy and I actually talk about these things a lot. We talk about the elbow all the time and all kinds of stuff. So the posterior interosseous nerve is something we kind of talk about. We talk about radial head a lot, and we also talk about the medial elbow. So the medial elbow really needs to close in if we have ECU problems or FCU problems, because if someone's more valgus, let me see if I can show you here, if they're more valgus, then that's going to traction the nerve through here. But if they're really valgus, then what you have is this kind of a rolling around kind of thing. And when that rolls around, then you've got issues with the AIN and the sensory branch of the radial nerve. And so a lot of times our perception is that everything's a motor nerve problem, but it could be also a sensory nerve problem. But either way, the radial head is one of these areas that is very mobile. It's influenced by bicep. So if somebody gives us information that they carried a load or they did something or they're holding a child for a long period of time, you want to look at bicep and its influence on the radial head. If that radial head changes its position, it doesn't just influence SBRN, but the posterior interosseous nerve. And again, if somebody's more chronic, they've now got this rotational part of this forearm. And you'll notice on these kind of more chronic people, brachioradialis will be overactive. So I think sometimes when we tape on the radial head, we're also influencing brachioradialis because
yeah, and you know, a lot of people that have TFCC problems have an overactive bicep. They've been doing too much bicep curling, and so the bicep is always involved in TFCC tears.
Yeah, and I think what happens is want to do, then they do these crazy things like they do the bench pressing, and then they want to do chin-ups, and which is disastrous because their elbow position is not actually right. So one of the big things we do is radial head taping, which influences all of these factors all together, because we really need to bring this back a little bit. So you anchor kind of on the middle part of the forearm, and this will help with pretty much the whole restoration of the whole upper limb. So you're going to do no tension, then you're going to do high tension, 75% at least, right to kind of do the ulnar border right here, to the right there, and then you're going to have no tension again. The key is if somebody's very, very neural down here at the wrist, then they're probably going to be very neural up here at the elbow. So if you take your piece of tape and it comes all the way around, sorry, I'll get that up higher, then, and they go, this feels great, but now I'm a little nervy in my fingers. All that means is you have to take this piece of tape back off so it doesn't cross this quadrant to this ulnar nerve side, because that nerve is so heightened. And if they're not super heightened, but they need stability, you can bring it usually all the way back around. But if they come out and you see them start to do something weird with their fingers, that tells you that they are too tension on that ulnar nerve, and you need to back it off. And usually you can just back it off to the border of the ulnar, drop it to the other side of the ulnar, and that usually takes care of that.
All right. Beautiful.
Yeah, helpful.
So, any of you guys have any questions about kinesio tape? And this is the lady to speak with. She's kind of the leading edge on knowledge of how to bring the neural tension and the biomechanics back into the elbow and the wrist. Thank you so much for joining. That's really nice of you to come last
minute. I was just crazy there for a minute, but thank you for having me.
All right. Well, next discussion about nerves, which we will be doing in the next couple of weeks. Have a great day. Does anybody here have questions? Can somebody anybody grab her, ask any questions? Island Daisy, would ECU pain include pain on the ulnar side of the hand between the base of the pinky and the ulnar styloid? Yes. Yes. Yeah. Any other questions? All right. Well, it is the end of Instagram Live Sundays with Alison Taylor on ECU. I hope you guys find this helpful. Have a great week. We'll see you next week. Bye, Alison.
Bye, Wendy. Good to see you. Bye.
Okay. I'm going to give everybody a last chance to ask any questions, and we'll sign off for now.